So, hello, my name is Preeti Minhas, and I'm the Assistant Director at Education for Health. We're delighted to join you to a series of podcasts and webinars to support World Heart Day. And I'm delighted to be joined by our two guests today from the British Society of Echocardiograms, Andy Potter and Tom Ingram. So can I invite you both to give a couple of introductions about yourself and a little bit about your role?
Thank you very much. Good morning. As you said, my name's Andy Potter. I'm a GP partner in Milton Keynes. I'm also a GP with a specialist interest in cardiology. I work in a community cardiology clinic, and the GP and the GP representative for the British Society of Echocardiography. My other role as well is I'm the clinical lead for our local ICS for long COVID as well. So we run a long COVID assessment and management service as well.
My name's Tom Ingram. I'm a consultant cardiologist based in Shropshire. My subspecialty interest is in cardiac imaging, and I sit on the Clinical Standards Committee for the British Society of Echocardiography.
Great, thank you so much for both for joining us today. Obviously, this podcast is aimed at building the knowledge and know-how for healthcare professionals around cardiovascular. So I'll start by asking you both, start with you, Andy, in terms of how do you see the primary landscape forming around cardiovascular conditions? So I guess, what are you seeing? What are you not seeing?
So there's been a big change with COVID, of course, with lots of remote assessments being done in primary care throughout the pandemic. I think many practices now have gone back to face-to-face assessments. I think that's had a big knock-on effect in how patients have been assessed. So lots of telephone assessments or video assessments where they can't always be examined. We've noticed in our community cardiology clinic, where we accept referrals from primary care, an increase in referrals and patients presenting with breathlessness and swelling where the GP is worried about heart failure. There's a lot of backlog from where we had to reduce our clinics during the COVID pandemic. So we've got a backlog that is built up, which is reflected in all echo departments across the UK, but also patients did not wish to be seen and did not want to be seen a lot of the time, so kept their symptoms at home with them and are now presenting. So that's resulted in an increase in patients being referred. Also, a lot of patients, particularly those that are in the shielding groups, have become really deconditioned. So they've been getting out much less, doing much less exercise, and that's had a huge impact on their breathlessness in particular. So we've definitely seen more patients coming to us with worsening breathing problems and worsening swelling. And some of this is because of delayed diagnosis, but a lot of it is because they were advised to stay at home and stay safe. So it has given us a backlog and an increasing waiting list for important diagnostics.
Great, thank you. And Tom, in the kind of secondary care landscape, how has that changed, or how has that been evolving?
So thank you, Preeti. A lot of the issues, generic issues Andy's describing, translate well to secondary care. The delayed presentation and therefore late presentation with pathologies, which are that bit more complex to tease out what's going on. I think workforce issues are critically important. So not only have we got this big backlog to catch up with, but we've lost a lot of staff who've just not been replaced during the pandemic. And personally, from a cardiology point of view, the specialty really suffers from not having any targets or 2-week wait attachment to it, because resources are absolutely being diverted elsewhere to planned surgery catch-up, to urgent cancer diagnostics, which are both incredibly important, but by definition, with a zero-sum game that we work in for NHS finances, that money comes from elsewhere. And certainly that there is not the emphasis being placed on resolving these cases. And as a consequence of all of that, we are having to divert a huge amount of our attention to managing inpatient work rather than outpatient work. So just at the time when outpatient work's really exploding, we're actually needed more and more on inpatient work because we cannot remove patients, safely discharge patients from hospital, and they're coming in with a much more abrupt stage of their pathology.
Great, thank you. So that really explored the kind of challenges that we see in both primary and secondary care. So I guess in light of some of those challenges, particularly around workforce, what can we as healthcare professionals really do to tackle some of those challenges and support, I guess, with the backlog, particularly for those healthcare professionals that have been redeployed into cardiovascular or are broadening their knowledge? So should we start with you, Andy, around what can we start to do in primary care?
Thank you. Yeah, there's lots that can be done in the GP surgery or in primary care to help make sure that we're getting the right patients onto those, unfortunately, long waiting lists. One of the concerns we have as clinicians is not only the patients that we are seeing, that the patients in front of us, that the patients that we're focused on when we're seeing them, but it's also all those unseen patients on the waiting list that have been referred as well. So we need to make sure that we're getting the right patient into the right appointment at the right time, particularly when it comes to diagnostic tests. And there's lots of patients that come to our community clinic. So these are patients that have been to see their GP or pharmacist or nurse practitioner or physician's associate in the surgery. They've been referred on because they're worried about heart failure, because they're presenting with breathlessness or swelling. And actually, lots of them do not have that as an end diagnosis. And there's lots of things that can be done before referral to help us decide if an echo, for example, is the best test for them and when that echo might be needed. It's very difficult for clinicians with heart failure because we know that heart failure can present vaguely with tiredness, with fatigue, with poor sleep, with swelling and breathlessness. But actually, the patients that we see and the patients that I see in my GP surgery, those that present with tiredness and swelling and breathlessness, most of those don't have heart failure. But it is important we pick those out appropriately because we know that there's lots of disease-modifying therapies that really improve long-term and short-term outcomes, stop these patients going into hospital and make them feel better and live longer. So it's really important that we get the right patient onto those lists for their echo and get them done soon. So the sorts of things that's important right from that first presentation is the basics in it first. So a good history, a good examination. Is there any evidence of atrial fibrillation, for example? Does this patient have a background of cardiovascular disease? Do they have ischemic heart disease in the past or any heart rhythm problems that puts them at increased risk of having heart failure, and that means they might need to be seen sooner? So a physical examination for patients is key to identify those sorts of problems. And a past medical history, is there cardiovascular disease, hypertension, diabetes, all those other risk factors, which mean heart failure might be a more likely diagnosis here. The key thing that we see, or a common thing that we see in our patients referred for echo with ankle swelling, is check the medication lists. Are they on amlodipine and gabapentin and these other drugs that will cause swelling if patients are less mobile than they used to? An ECG is vital to detect heart rhythm problems and any abnormalities, which again might mean that patient needs an echo or a specialist assessment sooner. Then probably the best test that's been used much more widely in the last 5 to 10 years is natriuretic peptides. So this is BNP or NT-proBNP. So these are chemicals that are released from the heart when it's under strain or stretch or stress. And these could be very easily picked up in a simple blood test. And a very low natriuretic peptide level with a normal ECG and a normal examination can help us be reassured that heart failure is unlikely a cause of these patients' symptoms, and that should direct the clinician to look at other causes of swelling and breathlessness, such as COPD or other problems. The other benefits of doing a BNP or NT-proBNP on patients in primary care is it, again, higher levels will help us determine that this patient will need an echo sooner, as very high levels of these peptides will point to it's more likely that they've got heart failure or other heart valve disease. An example is a patient we had referred to us in our community clinic, where the GP had picked up a loud murmur. He had breathlessness only for about 4 weeks, and an NT-proBNP was 27,000, and the normal is below 100. We got him in for an echo the next day, and he has very severe critical aortic stenosis. So he's been referred on for secondary care. So by doing that test, rather than him waiting 12 to 16 weeks for an echo, we got him in the next day, because we know that very high level strongly suggests there's some serious pathology going on, and lo and behold, he's now been referred for an urgently to secondary care and then tertiary care for a valve replacement that he needs. That's a good example, just in this last week, of how using that test allowed that patient to jump right to the front of the queue and get the scan that he needed, so he can have the treatment that he needs as soon as possible.
So I guess that's a really good example, isn't it, where actually we've used the facility of diagnostic tests appropriately to get the most, I guess, vulnerable patients and the most urgent patients to the front of the queue, ready to be seen in secondary care. So I just, moving on to Tom then, I guess in terms of the referral pathways, which guidelines, etc., do you feel that our healthcare professionals should be using when we're looking at patients?
So, thank you. It's fascinating, Andy, what you're describing there about using our clinical skills in the combination of biochemistry, ECG, physical examination, history, to really make an almost bedside assessment and bring that patient to the front of the queue. And clearly, the issue with heart failure is that not all pathologies have the same therapy with a label encompassing them of heart failure. So a single pathway is clearly not going to capture all those patients. And it does come back to having that clinical suspicion and taking time on that case, and perhaps a second visit to see where you are with them. I wanted, if I may, to focus slightly on the other end group, which is the ones who we kind of feel need reassurance, I think, for want of a better term. So we've all got this kind of evolving throughout our careers spider sense for picking out these high-risk patients, and we'll all have little examples of how we can do that. And I think it works very well, and the tests out there do point us in the right direction. It's these lower risk group, and I think there's always that fear amongst all of us, myself in secondary care, that we're going to miss things. And so echo's this kind of fantastic test, if you like, because the heart's so hidden in the chest, and physical examination, etc., does have its limitations, and it comes back as a kind of black and white report. And I fear sometimes we get lulled into a false sense of security that as a diagnostic test, it gives us a line in the sand between pathology and normal. Whereas absolutely, the cases I see coming through, we need to respect the fact that echo is a physiological test. It's not an anatomical test. It's not like looking for a cancer on a CT scan where it's there or isn't, and those kind of tests which are going to lend themselves well to artificial intelligence in the future. Echo gives you a range of results. And so if we're going to be taking these lower risk patients, not only are we going to not be allowing our high-risk patients to get early access to treatment, we also run the risk, if we scan all of them indiscriminately, that we're going to pick up a lot of incidental findings. Mild mitral regurgitation, for interest. I'm sure everyone who's requested an echo has had that back in the report. And it's then the other thing about UK echo services is it's not clinician run. It is run by physiologists. They're very highly trained. They are fantastic, but they are not cardiologists. They don't have that additional set of skills to pocket that report within a patient context. And so the responsibility will remain with the referring clinician to know what to do with that report. And I do fear sometimes you can end up in an awful rabbit hole where you just do a test for reassurance. It comes back with a kind of abstract on the fence result. You're then not quite sure what to do with that. Do I go for advice and guidance? Do I do a referral? My outpatient referral's a year. The patient's back in 4 weeks, very anxious because what they wanted was reassurance. And so the British Society of Echocardiography has come up with some guidance for primary care colleagues, just to say, in these situations, we think an echo will be of low clinical yield. It's not to say we're denying you access to it, because at the end of the day, it's your choice as a referring clinician if you think the patient needs an echo. It's just to give some confidence that in the experience of the group, the national body, these situations, such as Andy was describing with a normal ECG, normal examination, etc., low BNP, an echo is unlikely to be helpful. And it helps you just to park the case at that point rather than entering into this rabbit hole.
That's really helpful, and I think it's what we said right at the beginning, isn't it? It's about using the right tests at the right time, and that will help with dealing with the challenges that we foresee today. So you mentioned some of those resources that the British Society of Echocardiography has produced, which are absolutely brilliant. And as part of World Heart Day, we'll be sharing those, particularly around some of the features that we've seen in the practice nurse, that as the national body, so the member of National Alliance for Heart Failure, we will certainly be sharing to support people. Is there any other resources that together you would recommend to really support clinicians in this area?
Certainly, the NICE guidelines on assessment and management of heart failure are very clear and echo that. Sorry for the pun, but they do reflect that physical examination, ECG, and biochemistry. So NT-proBNP or BNP as a way of understanding if heart failure is likely here. And that's really what these guidance or how we want to help clinicians is, when you have a patient in front of you with often quite vague symptoms, is it likely that heart failure is the cause of their symptoms? And the NICE guidelines are very useful, and in primary care we make use of clinical knowledge summaries, which are produced by the same organisation, are very clear and very helpful on in which patients you suspect heart failure. So definitely I'd recommend those two.
And I would recommend very much tapping into the advice and guidance structure, which has been encouraged by NHS England to link primary and secondary care. The particular value you get out of advice and guidance is if you ask key questions. So just saying, is this heart failure? They're breathless. Well, I'm not going to know at the end of a keyboard. But if I have shared maybe an ECG and a BNP result and those initial tests and saying they've got a normal examination, then rather than triangulating your thoughts against an echo, triangulating them against a specialist via that process can be just as effective. And I know my wife's a GP, and often patients, she's able to strongly reassure them just by saying she's had a conversation with a cardiologist, rather than the reassurance of the echo. And Andy and I were talking before this podcast today about how there's a kind of myth out there that patients want tests. I think patients want reassurance, and it might be a test gives you reassurance, but it may be these other structures available give reassurance, sharing with colleagues, discussions, time.
And that's a really valid point, isn't it? Because there's a lot of work being done by the University College London around patient behaviours. And actually, when we have that consultation with them, it's around looking at that person's beliefs, etc., and really taking them and walking in the patient's shoes. So I think you're absolutely right in terms of some of the myths that we presume as healthcare professionals. So that brings us to the end of this podcast today. Thank you once again to both Andy and Tom for giving up your time today and for taking part in this podcast. And we really hope that this podcast has supported you to build your knowledge and know-how around cardiovascular conditions, in particularly the topic we discussed today around echo. So thank you very much. And We have further resources available on our website, which is www.educationforhealth.org, as well as our partners at British Society of Echocardiograph have a number of resources to support you. So please do visit both of those websites. Thank you very much today.